Okay, I think we are set. So, uh, good evening, everyone. Welcome again. It's another Sunday, and as usual, we are going to have the Afro DX unknown case solving. It's David again solving a case. Today's case, David, will be very nice. Uh, it's the case that I saw, and I'll present it the way it came to me. The best information of the case, I believe, will come from your reflection, because as you see at the end is somehow not a finished case. And to start with an outliner, we have a 55 female who is presenting with a dysphagia for 2 months.
Okay. Yeah. Now, just hearing that today's case will be a very nice case from Joseph, I think that is scary. Uh, but I'll try anyhow. So dysphagia, I think dysphagia is not so after finishing medical school, undergraduate studies a number of years ago. I think it's not a complaint that I come across frequently, because many times I think many of us, when we hear dysphagia, we think about surgery. But then so I'll apply my slow thinking today, because I'm not sure if pattern recognition will work here. So a 55 years old female presenting with dysphagia for 2 months. Okay. So dysphagia, basically we are talking of difficulty in swallowing. And if we are talking of difficulty in swallowing, I think maybe just to start broadly, I'll think about broad categories. We could be dealing with something mechanical. And just like I said, it's very broad and undifferentiated, something mechanical. And when I say mechanical, I'm thinking of things like uh, someone has, for example, an esophageal tumor, that is mechanical. Or someone has a Ezenka's diverticulum, or someone has an esophageal web, that will be mechanical. But then we could be dealing with something neurological. Now, neurological again is very broad here, but then something neurological, like someone could come with dysphagia uh, as a result of some neurological disorder. So, for example, we have the so-called esophageal dysmotility disorders. I'm not sure if I can call them precisely neurological, but yes, esophageal dysmotility disorders like achalasia. But then other neurological, you also have neurological conditions that can present with dysphagia. So very broad at this point. I not very well organized, but I think with more information, I'll narrow down and know which path I'm taking.
Okay, so this woman noticed gradual onset of difficulty swallowing 2 months ago. It started with larger solid foods and progressed to involve smaller solids. She reports no difficulty with liquids. Okay, yeah, and she reports to feel food stuck on the lower part of the chest. The difficulty in swallowing is associated with painful swallowing, choking when eating, and cough, but she reports no difficulty in breathing. She reports loss of appetite and significant unintentional weight loss over the same time period, but she denies abdominal pain, diarrhea, nausea and vomiting, limb weakness, muscle pain, skin rash, or visual disturbances. That's HPI.
That's all we have for the HPI.
Yeah, that's HPI.
Okay. So the difficulty in breathing, the difficulty in swallowing, the dysphagia that we are talking about for 2 months. And then this difficulty in swallowing seems to be progressive. Started with uh, larger solid foods and then progressed to involve smaller solid foods. But at least for the moment, because we are talking of a 2-month history, so she doesn't have any difficulty with liquids. And she reports that she has a feeling of food being stuck on the lower chest, and it's associated with painful swallowing, choking, and cough, but no difficulty in breathing. What is significant here is that this is associated with so there is loss of appetite, significant and intentional weight loss. Okay, so the weight loss here is an alarming symptom. Uh, Someone presenting with difficulty in swallowing and then having weight loss, we definitely have to be very vigilant to what's going on here. And the loss of appetite, of course, maybe weight loss, we could say if the patient is having, we could have an assumption that if the patient is having difficulty in swallowing, then the eating is not proper. She's not taking in enough quantities of food, and that's why she's losing weight. But the weight loss could be due to something sinister, like a malignancy, um, an infection, or some autoimmune disease. And the difficulty in breathing, because it's progressive, I'm tempted to think about something that is progressive in the same area. So, like you have a tumor that is slowly growing, and that's why the patient is initially having a problem with swallowing larger solids, but then smaller solid foods, but no difficulty with liquids as yet. So. Uh, I think that the HPA hasn't really helped me much in making progress. I'm just thinking maybe still it could be mechanical, like I said earlier, or it could be due to something neurological. But then there's something else that I need to discuss here. The patient is also having odinophagia. There's painful swallowing. So when I think about odinophagia, there's a number of things that I think about, because as I said, for years now, I think it's not a very familiar complaint that I come across many times. So I have to think about some things, especially infections. Infections like esophageal candidiasis, like CMV. So that kind of infections that could present with odinophagia. But again, something mechanical that is ulcerating can also present with pain during swallowing. So uh, again, not made much progress, but I'm entertaining a number of possibilities. So I'll see further information how it will help me to arrive at the diagnosis if I can.
Okay. Review of other system, not much. Cardiovascular system and musculoskeletal system were reviewed, which were unremarkable. Past medical and past surgical, she has no known chronic illnesses. The only past surgical history is that she had a cesarean section at age 26, which was unremarkable. Family and social history, she's widowed. Husband passed away through a motor traffic accident some years ago. She has one adult child. She's a policewoman. She's a non-smoker. She drinks 2 light beers per week. She has never used illicit drugs. Mother is alive with DM and hypertension, and father is also alive with BPH and dementia. She has 4 siblings who, together with her son, they have no known illnesses.
Okay, so the, the past medical history is non-contributory. So I mentioned some things like the patient presenting with odinophagia. There's a number of things that I was thinking about, like I mentioned the possibility of esophageal candidiasis, uh, CMV esophagitis. So you could also add others like uh, esophagitis from herpes, and other infections, but these infections are common, or we expect them in people who are immunosuppressed. So uh, people with immunocompromising illnesses like HIV, like diabetes, someone who is having a malignancy, or someone who is on immunosuppressive medications. But then the past medical history uh, does not bring attention to any of those to those illnesses I just mentioned. And then the family social history. So when we talk about a possibility of malignancies, esophageal malignancies, and related conditions, cigarette smoking as well as alcohol consumption are risk factors. But then the patient doesn't have a history of smoking, and does not have, so she's a social drinker, a few drinks, although at the moment we say there is no safe level of alcohol, but maybe that's not very significant to think about an increased risk of esophageal malignancies, for example. So I think the family social history as well as the past medical history uh, have helped me in terms of important negatives that there is a number of things that I would consider, but I'm not considering at this point, given that the patient doesn't have a significant past medical history. Yeah, so more information.
Okay, we move on to the exam. She's alert. She's not in distress. She has temporal wasting. She's a febrile. She's not pale, not jaundiced, and she doesn't have lower lymphedema. Vital signs are unremarkable. Systemic exam, per abdomen, she has a normal contour with a non-tender abdomen and no organomegaly. Chest exam, she has crepitations on the left inframammary and the infrascapular regions. The neuro exam, cardiovascular, musculoskeletal, and skin were all unremarkable.
Okay, now I get it when you say this is an interesting case, and maybe what's interesting will come in the reflections. So the physical exam, I mean, apart from the crepitations on the left inframammary and infrascapular regions, the physical exam is quite non-revealing. So the crepitations, uh, I mean, just one assumption that I'm making, we heard that this patient is choking and she coughs when she eats. So I would think there is probably a possibility that she aspirated, and so we are probably talking about an aspiration pneumonia. That is one thing I could think about. Now, whether these are two different pathologies that are overlapping at some point, I'm yet to figure that out. Uh, then the abdominal examination, I mean, if we are dealing with something, I mean, with someone, for example, with an esophageal malignancy, we do not really expect to find much on the abdomen, except maybe that the patient is wasted with a scaphoid abdomen. And then neurological examination, because I was thinking about, I mentioned the possibility of, uh, neurological conditions that can present with dysphagia. So, for example, someone with people can have stroke and present with dysphagia, and then we also have some neuromuscular diseases that can present with dysphagia. So, but then the neurological examination, at least on examination of the extremities as well as cranial nerve, seems to be normal. Because if we are talking about dysphagia neurological, for example, due to something like bulbar palsy, for example, we would expect some abnormalities on cranial nerve number 9 and 10, which are not present here. And then something else maybe that I didn't touch before is that a patient presenting with difficulty in swallowing, there is also a possibility that we are dealing with some autoimmune diseases. So, for example, systemic sclerosis can present with disorder. Uh, but then on musculoskeletal system examination as well as skin examination, we do not see anything that is remarkable. So systemic sclerosis and actually other diseases like inflammatory myopathy, so dermatomyositis and polymyositis can present with difficulty in swallowing also. But uh, the neurological exam, musculoskeletal as well as skin exam seem to be normal. So at least at the moment, no alarms raised about a possibility of those conditions. So again, not much progress made. More information.
Yeah. So maybe before we move on to the more interesting parts, maybe you could summarize on what we're discussing. I see some few people join later.
Okay, so this is Joseph has been presenting a 55 years old female with an unremarkable past medical history who has presented with a 2-month history of progressive dysphagia. Initially started with larger solid foods, then progressed to smaller solid foods, but she doesn't have any difficulty swallowing liquid foods. This is associated with loss of appetite and unintentional weight loss. On physical examination, nothing significant except for crepitations. Crepitations on the left inframammary and infrascapular area. Other general as well as systemic examination was normal.
Yeah, that's a fair summary. And so we move on into labs. White count was 7.5, normal differentials. HB slightly reduced at 10.8 with an MCV of 86.6. Platelet 277, ESR was 10, AST slightly elevated at 39, ALT, ALP.
Okay, Joseph,
Hello?
can I be can I spend a few minutes answering a call from my registrar because I'm on call today. So I'll be back in a short while.
Okay, no problem. Yeah, so for the rest of us, maybe what are some others thinking concerning these cases? We're waiting for David to come back. Anyone with some ideas? I see some fresh brains from the new physicians in town. Yes, Karibu. Mario, what do you think?
Good evening, doctor.
Good evening, Mario. Congratulations, bana. Karibuni kwenye competition.
Let's wait first mpaka September tuone.
Mnaisha hiyo.
Okay, I'm trying to synthesize the information first because I've just joined. Maybe I'll have some inputs after a minute or two.
Okay, sure. Shani,
Good evening, Joseph.
good evening, Shani.
Unfortunately, me Pia, I joined after the physical examination,
Hmm,
but it seems interesting with the physical examination findings I see.
sure.
I'm still thinking what it could be.
Do,
Yeah,
do, do you have
maybe the investigations might have.
do you happen to have an approach of yours concerning difficulty in swallowing?
Not not at the moment, but then I was looking at the same discussion that Dr. David was saying, the neurological aspect, the mechanical aspect, looking at what it could be, also
Sure.
looking at the patient being a female elderly.
Sure.
Yeah. So I think in the same lines that David was discussing.
Yeah, I agree with David's approach of neurological and mechanical. Yeah, it captures a lot of differential diagnosis, by the way.
Yes.
Anyone else? The physicians. Irene, I saw Irene here. Any thoughts? Azaura, you're the GI that we depend on.
Yeah, so I'm still thinking, but at this particular point, I would think the possibility of esophageal CA with tracheoesophageal fistula,
Sure.
as the patient is having weight loss, is having dysphagia followed by choking,
Sure.
and also the weight loss is the
Mm.
hallmark for possibly malignancies.
Yeah.
So until now,
Mm.
I would think the possibility of the esophageal CA with tracheoesophageal fistula
Sure.
and other differentials, as Dr. David was saying, the neuromuscular and neurogenic dysphagia, but I'll put them down on the list.
Yeah.
Yeah.
Thank you very much, Kazaura. You really proved to be a GI.
Thank you.
David,
Yes, I'm back.
I see you're back. So we were waiting for you here. We discussed some very interesting
Yeah.
stuff, and turns out all of them you just mentioned them. So we were refreshing our minds.
Okay,
Yeah. So here are the labs,
I'll
David.
be very much interested. I'll be very much interested to hear what Joseph was saying. I just came in to find an esophageal malignancy with tracheoesophageal fistula as one possibility. I'm not sure what other differentials he mentioned.
You'll find out at the end.
Okay.
Yeah. So she. Have you seen
Okay.
the
So
labs
you were just presenting the lab. So HB 10.8,
and the AST, which is raised?
MC. Okay, but all other findings. So MCV no, platelets count normal, ESR normal, ALT, ALP, bilirubin, creatinine, BUN, RBG all normal. Okay.
And we have
Do I discuss the labs?
maybe you can, because the lab's just two, and you can see this X-ray.
Yeah.
I think you can tackle them together.
Okay. So that's it.
Yeah, that's it.
Or do we have any other investigations?
We'll see them
Or
later.
that's it for the moment?
Yeah, for the main.
Okay.
Yeah.
Okay. So we see in the labs, in the complete blood count, a mild anemia HB of 10 point with the normal MCV. Generally, so it's we could say probably that it's anemia of chronic illness. So there's sometimes a little bit of esoteria. There's this distant syndrome that comes to mind, but then this patient doesn't fit in. So I think for that one, do we talk about iron deficiency anemia, and then dysphagia because of esophageal webs, and then there's something more. It's called Plummer-Vinson syndrome.
Yeah.
So I think after here, I'll have to go and review that syndrome, but I do not think that the patient fits in perfectly. And maybe later on, Joseph, you can teach us a little bit if you happen to go through it. So for that lab, I think that HB we see it's a nomocytic. I think nomocytic nomochromic anemia, and therefore most likely anemia of chronic illness. But then the AST is elevated. Can I see again the value?
It was 39.4.
Okay, 39.4. So not a very significant elevation from an upper limit of 31. Yeah, not a very significant elevation, and then the ELT is normal. Now I'm wondering if there's something going on in the liver, because it's a very mild elevation in the EST. So whether I think I'm finding it difficult to conclude, but then there could be a possibility maybe there is some hepatocellular injury that is happening. All this AST is coming from somewhere else. And then the chest radiograph, can I see it? Okay, so the chest radiograph, we see this sort of ground glass opacification on the left mid as well as left mid as well as lower zones. I do not see anything else significant. So maybe for this one, if there was anything striking you, you can just help tell me the radiologist's report. But otherwise, what I see is that opacification covering the left mid as well as lower zones.
Yeah, so radiologist didn't report, but again, I also find the same thing: reticular opacity on the left mid and lower zone.
Okay, do you have any other information? So this one, so it's not very specific. I mean, I cannot exactly commit that what we are seeing here is in keeping with the specific pathology. I'm considering a possibility that the patient aspirated because she's having choking from the coughing. But then if this tells us anything specific, I'm not exactly sure about that.
Okay, so
And it-
um, I referred this patient to a gastroenterologist, and he scheduled her for GD after 2 days. But at that point, I left the hospital because my time was up, and I left the case to another doctor who read the X-ray, listened to the patient, and prescribed this medication: amoxiclav, a cough mixture, prednisone, and multivitamins, with reasons that I'll tell you later. So after 2 days, the patient came back for GD. As I read the endoscopist notes before doing the OGD, he wrote that the patient had a chief complaint of abdominal pain. And his OGD report read like this: the esophagus had normal mucosa, the stomach had diffuse hyperemic patches in the cardia, atrophic mucosa with diffuse hyperemic patches in the body of the stomach. The duodenum had normal mucosa, and his conclusion was gastritis and duodenitis. So he started the patient on esomeprazole. He also ordered some further labs, which included CA125, which came back 5.8, and CA199, which came back 2.4, which were all within normal limits. Any comment?
This is interesting. I mean, for someone who is presenting with dysphagia as well as odynophagia, and then you do OGD, comes back with a report that you're just dealing with gastritis and duodenitis. So the esophagus is completely normal. So one of the one of the diagnoses that we were entertaining was an esophageal tumor that is presenting with the dysphagia, the progressive dysphagia. And then because of the odynophagia, we're also talking about a possibility of infections like esophageal candidiasis, CMV, and all the like. But then the esophagus is reportedly normal. So, I mean, I'm not a gastroenterologist, but I tend to think that, okay, the patient is presenting with dysphagia, and then the esophagus is reported to be normal. So what else could we be dealing with? So we are probably dealing with an esophageal dysmotility disorder. So, but then, which are basically, we do not expect to see anything mechanical in the esophagus, but then other studies like I think esophageal manometry and the like, motility studies, I think they are the ones which could be more revealing. But then I'm wondering, okay, if we are talking about an esophageal dysmotility disorder, I'm not sure how easy it will be to intubate the stomach with the scope. So that one I'm not sure of, because I'm not a gastroenterologist. But then I think at this point, of course, we almost, unless we are talking of something, something extramural, or something outside the esophagus that is compressing, in which case again, there would probably be difficulty in advancing the scope, and therefore something. So I think the endoscopist would report that there is a possibility of something compressing from outside. So maybe we are dealing with something of a motility disorder rather than something mechanical.
Okay. I had the same thoughts, but again, the case kept complicating itself. So I reviewed this patient again at the OPD on day 4, and now dysphagia had completely resolved, but the patient still had cough. So I prescribed azithromycin on top of the initial amoxiclav that she had. What do you think on this? What is going on here?
The dysphagia. Okay, so the patient. What I'm thinking of is, the patient was initially prescribed antibiotics. That was amoxicillin and clavulanic acid, but then she was prescribed prednisolone.
Yeah.
So I'm thinking maybe the prednisolone, as we know it, probably worked wonders in this patient, and that's why we see a resolution in the dysphagia. So I mean, that's one of the things that I could think explains the resolution in the symptoms of dysphagia, because of the prednisolone. But then the persistence of the cough, if my assumption is right that we are dealing with aspiration from the choking, so when someone aspirates, the commonest organisms are anaerobes, the oral anaerobes, and therefore something like amoxiclav itself wouldn't work, and therefore you need something to cover for anaerobes. Now, azithromycin itself, I think it's mostly for atypicals, but then for anaerobes, I think would also need something like metronidazole. So I'm thinking maybe the dysphagia resolved because of the prednisolone. But then what exactly caused this dysphagia that resolves with prednisolone, that still puzzles me.
Okay. It puzzled me more than it puzzles you. Then, over the next 1 week, so patient started to experience a progressive difficulty in breathing. That wasn't when she performed the movement from one area to another. And at one night, she had difficulty breathing, which was so severe she couldn't sleep. And she presented to the emergency department of the same hospital. So, on exam, she was saturating at 83 on room air, which improved 96% when she was put on 3 liters of oxygen through nasal cannula. She did a second X-ray and she performed some labs which were unchanged from the previous one. She did an echo which came back unremarkable.
Okay, I think this is an interesting case for real, and I think at this point in time, my goal is not to get the diagnosis right, but to just make sure that I think as clearly as I can. So the patient, so we have a new symptom, which is a progressive difficulty in breathing. So when I think of difficulty in breathing, I tend to think of it in terms of organ systems. That is the first layer in terms of organ systems, and then use an anatomical approach. So in terms of organ systems, I would say I think of difficulty in breathing as cardiac in origin, which doesn't seem to be the case here, with the help of this transthoracic echo. And so one more possibility I was thinking about. So at this point, I think I'm thinking about everything that comes to mind. A cardiac cause of difficulty in breathing and dysphagia, left atrial enlargement can present with dysphagia because of compression of the esophagus, but it is normal. So a possibility of something cardiac in origin may be not very likely, unless we are talking of an arrhythmia, which the patient doesn't, what we hear is difficulty in breathing and not palpitations. And then another organ system is the respiratory system. So the difficulty in breathing could be because of the opacifications that we see on that X-ray, treated with antibiotics but not improving. So that would be one possibility. We cannot throw out respiratory causes of difficulty in breathing in this patient. But I think another box that we need to open is to think about a possibility of neuromuscular disease. That the dysphagia that we are talking about is due to a neuromuscular disease, and neuromuscular disease, I mean all the way from the neurons to the neuromuscular junction to the muscles. So talking of the neurons, especially motor neuron disease, for example, amyotrophic lateral sclerosis ends up with difficulty in breathing, and I think that is what kills most of the patients. But then a common presentation of motor neuron disease like this would expect other striated muscles to be involved, especially the limbs. So I'm not sure if that will be high on my list at this point. So neuron diseases like motor neuron disease, for example, ALS, and then diseases of the neuromuscular junction, of course, myasthenia gravis, as well as Lambert-Eaton myasthenic syndrome can present with difficulty in breathing as part of the presentation. So a neuromuscular disease. And then coming to the muscle itself, a myopathy can also present. It can explain the difficulty in breathing, as well as the dysphagia. A myopathy, which I should probably consider in this patient, but then mentioning a specific phenotype, I think will be difficult for me at this point in time, because the patient doesn't seem to present with weakness in any of the limbs, and then it's just the dysphagia and then dyspnea. So it could be neuromuscular in origin, and those are the possibilities. Yes, so I think that is where I am. The new difficulty in breathing that we see could be explained by two things. I mean, the dysphagia from whatever cause, the aspiration pneumonia that is not adequately treated, or another possibility is we are dealing with the neuromuscular disease with the possibilities that I mentioned.
Sure. So are you sending any tests right now?
I'm not sure what tests to send. So just present whatever you have and see if I can if I can make any progress.
So she met a very intelligent GP who ordered HIV and came back positive.
Okay, this is very interesting. So I was I think I mentioned the possibility when we are speaking of dysphagia and odynophagia. Earlier on, I talked about, especially when I was discussing the past medical history, I said that the past medical history doesn't seem to be contributory, because that would explain if she's immunosuppressed, then we could be talking about something like esophagocandidiasis or CMV esophagitis, but then these were not found in the on OGD. They were not reported, and the difficulty in breathing that we were thinking about, I thought it's probably because of aspiration. Now this patient is desaturating, so maybe other possibilities like PCP, those could be explaining the difficulty in breathing. But I'm still wondering what was causing the dysphagia that improved initially, that improved after giving the prednisolone probably, and what was not found in OGD. But then yes, the HIV, I think it changes our thinking a little bit, thinking about a possibility of opportunistic infections that are presenting in this patient.
Yeah. So you are, I think you're on the track. You think that the difficulty in breathing is from the PCP probably, but again the dysphagia is still mystery, right?
Yes, I mean, at this point in time, I'm not sure what to attribute the dysphagia to with the normal OGD. So dysphagia and odynophagia, and then the OGD is normal, because if we are talking of esophageal candidiasis, it will definitely pick it. If we are talking of CMV or herpes or anything else, OGD was supposed to pick it.
Sure. I was in the same boat, and we treated presumptively the patient for PJP pneumonia, and we corrected her sputum for AFB engine expert twice, but they were negative. So after being treated like that, we weaned oxygen after 7 days, and we started ART after 4 days. We discharged this patient after 2 weeks from the admission date, and as of current, she is well and she's attending CTC. So still, yeah, the patient is well, which is the job that we doctors do, to make sure that we treat them. This is the final outcome. So we are on this right track. That patient is well. But still, if we go back and reflect in this case, it is still puzzles me to this day what is going on here. So I think this is the same to you, that if you think in retrospect what caused the dysphagia, you are not seeing answers, right?
Yeah, I mean, what exactly explains the dysphagia? I cannot think of anything like from the top of my head.
Yeah.
If you read case reports, I mean, you could probably come across something that the HIV virus itself, uh, due to some pathophysiological mechanisms, can present with dysphagia, but not anything that I know of, at least up to this point in time.
Yeah, sure. So on your left side, that's the my schema for dysphagia, and a little bit different from yours, that mechanical, neurological. This points to the it's anatomical approach, whether it's oropharyngeal, esophageal, how to locate it. If patients are telling you food is stuck at some point on the chest, you know that is esophageal. And the oropharyngeals, I will tell you, they cannot initiate swallow. Maybe food is keep rotating on the in the mouth. So truly, this was esophageal dysphagia. The patient clearly pointed to the point that food is being stuck, and it was a solid dysphagia, which translated into structural. But all the causes you are seeing them here, they can, most of them can be picked by an endoscopy, which didn't pick anything. So to this day, I saw this case some months ago, but to this day, it's a matter I will be sitting somewhere and thinking, and then it will come to my mind what was the cause of that dysphagia. I'll read, but still I couldn't get any answers. So first of all, if this woman, the biggest mistake I made for my part, because this HIV diagnosis was so late and I didn't diagnose it, just some other person. If this was a 32 years old woman, for example, I believe HIV would have been number one investigation. So 55, widowed, and I didn't thought that she could be sexually active. That was a big mistake. I missed HIV from the get go, because for me, if a patient presents with weight loss, I do glucose. I also do HIV. So maybe this dysphagia was not even related to the cough or the IB or HIV. As Kazaura was saying, I also thought maybe this old woman could be esophageal cancer with the complications of it that are causing the cough. But turned out maybe it is not even the case. Maybe these are two different entities that presented on the same day. So if this was esophageal candidiasis which causes the dysphagia, as David, you are clearly saying, the endoscopist should have seen it, because it's so easy, even for an untrained person. It's just to see white plaques, they're there, and you know they are candidiasis. But even if you think this endoscopist, because maybe he was so uncaring, even in the notes he put that abdominal pain, not difficult in swallowing. And I asked the patient, did you tell this person you had difficult swallowing? He said, yes, I told the endoscopist. But even if that was the case, so let's say it was he missed esophageal candidiasis, which is so unlikely. But why should it resolve without proper treatment? I checked whether this prednisolone and amoxiclav, they have an antifungal activity, but turns out they could worsen the disease, especially the prednisolone. So it resolved, which means maybe it was not esophageal candidiasis. So the other thought that I kept entertaining, that maybe this was esophagitis that should respond to prednisone plus or minus PPI, because this patient was also on PPI. So the answers that I came up with through reading include, in the patient with HIV, HSV and CMV esophagitis. But again, these, when you put in a scope, you have to see ulcers or some lesions that will point you toward their diagnosis. But one particular cause is very interesting, the eosinophilic esophagitis. So in this eosinophilic esophagitis, the endoscopy can be normal. It only needs histology for diagnosis. Yes, you can see things, but endoscopy, it is not diagnostic of eosinophilic esophagitis. You have to do biopsy, so you can find a completely normal esophageal mucosa. So I sit here, maybe this was eosinophilic esophagitis, which is not even related to the HIV and the PCP that is going on. Another entity is GERD. GERD also can cause dysphagia, but patients, they will tell you they have GERD. It is long-standing complication of GERD, the dysphagia, when it presents with GERD, which this patient didn't have. So yes, I can't say for sure I have answers. I wish I could convince those endoscopists to go back again and take a biopsy and send it. We see if we can count the eosinophils, but patient is well and you cannot tell them that. So that's the case for today, David. It has been in my mind for such a long time, and today I shared it with you. Do you have any reflections, maybe?
Thank you, Joseph, for the case. So a very interesting case. very interesting case, and I think I'm speechless at this point. So a number of things that we are entertaining, that we are thinking of, but then of course I just like you say that you made the mistake, so you made the mistake of not testing for HIV. I also made the same mistake in assuming from the history that because we did not hear about the history, then maybe this patient is not having any form of immunosuppression. And that's why I threw out all the possibilities that I explained my immunosuppression, which I of course considered at the beginning. So I think it's a good case for learning, to remember not to casually assume things that because I did not hear it in the history, it's probably not present. Of course, it doesn't. Maybe it does not explain everything. It explains the difficulty in breathing that improved after treatment, but then maybe it does not completely explain the dysphagia. But then I think it's something that I myself would have thought about asking for that test if it was done. So I think it's been a good learning case. Of course, jogging my reasoning and then also revealing gaps that I need to go and fill, including not casually assuming things. So thank you very much.
Have you ever read or maybe a case of eosinophilic esophagitis?
I do not remember reading a case. Maybe I think I've come across that term,
Yeah.
and I'm trying to think that in the Najim cases that I read every now and then, I remember coming across a thing like this, but I do not remember the details of the case.
Sure.
Yeah.
Yeah, that was it. Okay,
Okay.
people.
Thank you very much, Joseph.
Yeah, Karim.
So yeah, the floor. If anyone has any contributions, we'll be happy to hear contributions, questions, anything.
Yeah, Joseph.
Yes, Joseph, thank you for a good case, and David, thank you for jogging with. Um, so the case was a bit difficult, and I think until now we don't have a diagnosis.
Yeah.
But I was wondering from the chest X-ray,
Yeah.
that chest X-ray, I would also see the left lung volume is also reduced on top of the infiltrate that was seen. But if you look carefully, you would see there is a significant reduction of the left lung volume. So the right lung is a bit large compared to the left lung. I don't know what could explain that. And as David pointed out, I also we had a case which I think we presented with Dr. Irene, and this was a child who had chronic diarrhea, and so the colonoscopy and the biopsy revealed the child had eosinophilic colitis, if I remember correct. So I think, David, your memory maybe is from that case. And again, as Joseph said, I think there was a problem with the results from the endoscopy. I'm not sure. I can't tell for sure. What I know is that if you have any form of esophagitis, there should be some evidence of inflammatory response in the esophagus. So it is difficult to have a normal esophagus. I don't know, but I believe it is a bit difficult to have a normal esophagus and at the same time you have esophagitis.
Okay.
I think is something that I also have to go and learn, and I think read more on this case.
Yeah.
Thank you.
Yeah, thank you very much, Kazaura. As I said, you are the GI. Yeah, so yes, I can see what you're saying on the X-ray, but I can't make of anything. And another thing is, this woman had serial X-rays which were done when she was receiving treatment. I I can't recall if they also showed such a thing, but I don't know. Maybe position. I don't know. I don't know. But there is no any other pathology as now she's doing very very well. Or maybe it's, if I can review the X-ray changes of PCP pneumonia, I can see such a thing. I can't tell you for sure. But yes, thank you for your comments on the case. So except for eosinophilic esophagitis, yes, I didn't see any other that you there have to be esophagitis. But for eosinophilic esophagitis, it can be normal the way the literatures are reporting it. And the endoscopy is not a diagnostic. You have to that's why you have to perform a biopsy. Maybe David, you have something to add on that.
Yeah, no, I also I'm not an expert in that. I'm not exactly sure. So the forms that can present. So you have esophagitis and then OGD normal, apart from what you've mentioned, which is again new information for me. So I think it's an area to go and read more on.
Oh, sure.
Anything else? Anyone?
Yeah.
I do not see any. I do not see any hands. So I think people are reflecting on the case. Okay, so if there is nothing else, I think the audience is quite modest today. But then, yes, I see a comment here from Dr. Nasrin that the ESR the ESR was misleading. Yeah, so probably because so uh, this patient was having, but then I'm also trying to think. Okay, patients with PCP, maybe Joseph, if you can, if you have the information handy
Mm,
at this point in time, if let's say we have a patient with PCP,
mm,
do they normally present? I mean, maybe 100% of the time present with elevated inflammatory markers like ESR, but then of course I would be tempted to think the same, that maybe with the presentation the patient had, we see a possibility of esophagitis, for which we do not have the cause,
mm,
but then the pneumonitis that we see that was presenting with the dyspnea, maybe we expected the ESR to be elevated, but then it was normal in this patient.
yeah.
I'm just not sure. I think I would need to review the characteristics of ESR in patients with something like PCP.
I've,
But then I'm tempted to think the same way, that okay, the ESR maybe it misled us in this patient.
yeah. So first of all, I've seen quite a number of PCP patients, and in reading, PCP in HIV to be precise. I don't think if I ever seen ESR to be that much important, given that this patient are immunocompromised, because to get a PCP, you have to have a pneumonia, I mean, a CD4 less than 200. So you are very immunocompromised. You cannot even mount a proper a proper immunity against the infection. What I know that is being written in many of the literature, if you can do them, is an LDH. An LDH is to the roof if you can perform it in patient with the PCP, either they are immunocompromised or not. I don't remember to have seen about the ESR, but thank you for that comment. That's very good, because now I have to go and read about ESR in PCP.
Then I saw a hand from Irene. Irene, karibu.
Hello, thank you. And thank you, Joseph. Joseph, I wanted to ask, what was the treatment offered to patients apart from the treatment
Irene,
for...
can you adjust your microphone, because you are very distant, and there is an echo in your voice.
Okay, hello.
Hello.
You can hear me
Hello.
better?
Yes.
Yes, clear now.
David, can you hear me better now?
Yeah, clearly.
Hello?
Yes, we can hear you, Ida.
Hello. Clearly heard. Irene.
Uh,
No, she disappeared. Maybe she'll come back soon.
yeah, but
Anyone else while we are waiting
I
for?
think she was asking what was the chief complaint.
Okay, no. Joseph, can you hear me better now?
Yes.
Oh, yes. I was asking what treatment was the patient given apart from the prednisolone and treatment for pneumonia. I want to see that before I comment.
Oh, okay. So, prednisolone, amoxiclav, some cough syrup, and a PPI. So this was the first, and multivitamin. And then after OGD, she received PPI.
Okay. How long was the duration of PPI?
Yeah, so she was prescribed for a month, but the day I saw her, from the use of PPI was like 2 days.
Oh, okay. And how soon did the dysphagia disappear from the initiation of medication following
Yeah.
OGD?
Uh, okay. Okay. So it seems it disappeared before even OGD, because the day she came back to the OPD clinic is the day that she came. It seems they took a biopsy, but we didn't see the results. She came on the next day after OGD, and she told me she doesn't have dysphagia.
Okay.
Yeah.
Because I'm really trying to reflect on this case and the fact that yes, we had presented a case of eosinophilic colitis, I and Dr. Kazaula at some point during our residency, and so I happened to read a little bit about other GI, because it could be anywhere in the GI tract. It could be the eosinophilic esophagitis and whatnot. But then now, so it's one of the possibility, as you say, that the OGD does not rule it out, although in some instances there could be overt findings in the OGD. However, you need a biopsy and the quantification of eosinophil count
Sure.
for you to say if it is eosinophilic esophagitis or colitis for that matter. So when I reflect upon this case now, how the symptoms are resolved,
Doesn't make sense.
so there's no temporal relationship of symptom resolution to treatment, because I think I remember when I read about it, the eosinophilic esophagitis. Initially it was considered a part and parcel of the gastroesophageal reflux disorders,
Oh,
that a patient with GERD could also present with the eosinophilia in the esophagus. So I think in the diagnostic criteria, they had included a fact that after you have done your OGD, you have taken your biopsy, you have your quantification of eosinophils, then you give a trial of PPI for at least 8 weeks, that is 2 months. And if a patient's symptom resolves, the symptoms of dysphagia resolves, then you consider that as either part and parcel of the gastroesophageal reflux disorder, or PPI responsive eosinophilic esophagitis. If, however, after the PPI, you have to repeat the OGD again. And if after PPI and you repeat the OGD and the eosinophil count is still more than 15 per high power fields, then it remains to be now eosinophilic esophagitis, for which I think one of the treatment was steroid. But now looking at the way symptoms resolved here in relationship to treatment, it's unsettling. It's unsettling to place it in one category, which I think at this point in time, the biopsy is really crucial. Because I can't think of anything else that would have a normal OGD and that looks like no treatment was offered that led to response. I'm still thinking what is really happening. But if we want to entertain a diagnosis of eosinophilic esophagitis, I think biopsy, following up on the biopsy result, is really crucial, because if this patient comes back again with dysphagia, I think again you start going throughout the whole loop again, trying to look at other causes. Because I think some rumino causes could as well be picked during OGD. And sometimes for example, if we think of disorders, for example, involving the aorta, that could be compressing the esophagus externally, a chest X-ray from the beginning would start to show us some of the features, perhaps. And then the OGD would really help tell. So I'm really still thinking if it is really eosinophilic esophagitis, and I don't know if this patient comes again presenting with this dysphagia. I think it's important to follow up on the biopsy result if that's possible, to see what exactly transpired, what was going on in the esophagus. I thank you for the case, and I think there's a lot of things that that do trigger to go and read further. And what I want to ask you, Joseph, why did you think HIV was directional changing in this case?
Directional changing in which sense?
I mean, you felt like the one who ordered HIV. Of course, it is an integral part, the evaluation of a patient who has dysphagia, and you think of all these other possibilities, including infectious causes and whatnot. The way you put it, at some point I felt like, okay, now maybe perhaps it's going to be contributory as far as dysphagia is concerned.
So for example, if this patient, if I tested HIV on the first day, I wouldn't go down the line thinking, because my thinking was this is esophageal cancer with complication. And then if I tested on the first day and I saw the infiltrate on the chest X-ray, I saw the dysphagia, I think, okay, this is HIV, probably advanced HIV with esophageal candidiasis, and probably we're dealing with a PCP, a persistent cough with such an interstitial infiltrate on the side that is unusual for aspiration. Probably I would have thought in that way. That I blame myself, because HIV diagnosis was made some days, not even by me. So that's it. But we are on the same boat about the cause of dysphagia here. That's why I called this a mystery case. I don't know what is the cause, but I was trying to find out if we have the biopsy, because the biopsy of esophagus was not even taken. The endoscopist took the biopsy of the stomach, because he's thinking this is a gastritis. So if we have the biopsy of endoscopy and it says there is no eosinophils, there is only one thing left, which is functional dysphagia. But you cannot say that unless you've ruled other causes. The very nice, you are saying something which is very true, that previously the diagnosis was made as you're saying, but my recent reading is that is not the proper way to do it right as of now, to give PPI and do again endoscopy. If you give PPI, you just label them PPI responsive esophagitis, esophagitis. And if it is not, you know that this is it hasn't resolved on the first line medication, you go into steroids, which are topical steroid, and the reason is to avoid side effect of steroids. But what my point was is, what are the diseases that can cause difficulty in difficulty in swallowing, and then they can respond to steroid. That's where I came with that esophageal, esophageal esophagitis, which I also don't think is the final diagnosis. I don't know what caused the esophageal in this patient.
Okay, thank you, Joseph.
Very. Yeah, I think we are on top of the 15 minutes past on top of the hour. David, I believe we should cross.
Yeah. So thank you everyone for joining. I think it's been an interesting discussion. Again, underscoring the fact that what we do is really difficult. I mean, making diagnostic reasoning, I think that is the most difficult part of being a physician. So the most difficult part about being any kind of clinician. So that's why we do it in order to improve it every day, because we just do not think there is another way than to try and simulate real life experiences in an online forum like this one. So thank you very much everyone for joining. I see we have missed some usual faces that we see every single time, but then we have some new faces here. So I'd like to welcome you, and we will keep sharing the link through a number of ways that through which we reached you today. So we encourage you to be frequent participants of these sessions, so we can learn together. So thank you very much everyone for joining, and I'd like to wish you a good night and see you next weekend.
Good night.